Welcome to Lesson 13, Integumentary Surgery, Skin and Subcutaneous Tissue. In this lesson, we begin Part 2 of our 2026 CPC surgery course and focus on skin and subcutaneous tissue procedures, including lesions, excision, repair, and documentation. For the CPC exam, remember our basic workflow. Identify right pointing arrow, document right pointing arrow, measure right pointing arrow, select the code. The key is to understand exactly what was performed and match the documentation to the appropriate captain code. Let's begin integumentary surgery. Before we begin Lesson 13, let's review what you'll learn in integumentary surgery, skin and subcutaneous tissue. First, we'll identify where integumentary procedures fit within the captain surgery section and learn how to distinguish procedures involving the skin from those involving subcutaneous tissue. We'll also focus on lesion documentation and the basic differences between biopsy, excision, destruction, and repair. These distinctions are important because the procedure actually documented determines the appropriate code selection. You'll also learn which details the CPC coder needs to identify, including the anatomic site, procedure performed, and other documentation requirements. Throughout the lesson, keep our CPC workflow in mind. Identify right pointing arrow, document right pointing arrow, verify right pointing arrow, select the code. For 2026 accuracy, always verify the current captain instructions, surgical guidelines, code-specific instructions, CMS and NCCI guidance when applicable, and relevant payer or service setting requirements. And remember, this lesson is provided for educational and CPC exam preparation purposes. Always verify current official guidance before making actual coding decisions. Our goal is to build a strong foundation in integumentary coding so you can approach CPC questions with greater accuracy and confidence. Now let's begin with an overview of the integumentary system within captain surgery. The integumentary system primarily includes the skin and subcutaneous tissue, along with related structures such as hair, nails, sweat glands, and sebaceous glands. From a CPC perspective, it is important to remember that we do not select a surgical code simply because of the diagnosis. We must identify what procedure was actually performed, where it was performed, and what the documentation supports. Common integumentary surgical concepts include procedures involving lesions, such as biopsy, excision, and destruction. We also encounter procedures involving skin and subcutaneous tissue, including removal, repair, incision and drainage, and other documented surgical services. Our captain code selection workflow is: documentation right pointing arrow, anatomic site right pointing arrow, procedure performed right pointing arrow, technique and extent right pointing arrow, captain descriptor and guidelines right pointing arrow, correct code. A common CPC trap is confusing a skin procedure with a subcutaneous tissue procedure or selecting a code before determining exactly what was performed. For the exam, remember, don't code the diagnosis alone, code the documented procedure. So, when approaching an integumentary surgery question, first identify the tissue, confirm the site, determine the actual procedure, and then select the captain code supported by the documentation. Now let's look at an important distinction in integumentary coding: skin versus subcutaneous tissue. Before selecting a captain code, the coder needs to determine which tissue was actually treated or removed. The skin includes the cutaneous layers, while subcutaneous tissue lies beneath the skin and includes the fatty tissue layer above deeper structures. This distinction can affect code selection. Procedures may involve skin lesions, biopsies, destruction, or repair, while other procedures may specifically involve removal, treatment, debridement, or drainage of subcutaneous tissue. Here's an important CPC trap. The wound extends to subcutaneous tissue, so the subcutaneous tissue code must automatically be used. Not necessarily. The coder should not select a code simply because a deeper tissue layer is exposed or mentioned. Instead, determine what tissue was actually treated or removed and what the documentation supports. Your CPC workflow is: identify the tissue right pointing arrow, review the documentation right pointing arrow, confirm the procedure right pointing arrow, match the captain descriptor right pointing arrow, select the supported code. Remember this CPC memory rule: depth of wound does not automatically equal depth of procedure. The final rule is: code the tissue actually treated or removed, as supported by the documentation. Now let's focus on lesion documentation, which is critical for accurate integumentary captain coding and frequently tested on the CPC exam. Before selecting a lesion procedure code, carefully identify what the provider documented. Look for the lesion type, exact anatomic location, number of lesions, lesion size, required margins when applicable, procedure performed, technique, depth, and whether lesions were treated separately. For lesion excision coding, remember that the applicable code selection can depend on the anatomic site and excised diameter, including required margins when the code family specifies them. The clinical measurement should be established before the excision. A major CPC trap is using the pathology specimen size as though it automatically represents the lesion size used for coding. That is not necessarily correct. Always follow the applicable CAPTAIN guidelines and use the appropriate provider documentation. Your workflow is lesion type right pointing arrow site right pointing arrow number right pointing arrow size and margin right pointing arrow procedure right pointing arrow CAPTAIN code. Remember this CPC memory. Type plus site plus size plus procedure equals lesion code selection. The final rule is code from the provider's documented procedure and required measurements, not from assumptions or pathology specimen size alone. Complete documentation leads to accurate lesion coding. Now let's compare three important integumentary concepts: excision, destruction, and biopsy. The first is excision. The purpose is to surgically remove the lesion. For the applicable skin excision code families, code selection can depend on the anatomic site and excised diameter, including required margins when the CAPTAIN instructions specify them. Your memory rule is excision right pointing arrow remove it. Next is destruction. Here, the lesion is destroyed rather than surgically excised. Examples can include techniques such as cryosurgery, electrosurgery, laser treatment, or other methods described by the applicable CAPTAIN code. Remember, destruction right pointing arrow destroy it. Finally, we have biopsy. The purpose of a biopsy is to obtain a tissue sample for diagnostic examination rather than necessarily providing definitive treatment of the entire lesion. Common skin biopsy techniques include tangential, punch, and incisional biopsy. Your memory rule is biopsy right pointing arrow sample it. Here's the CPC trap. Any lesion removal is an excision. That is not correct. The intent, technique, and documentation determine whether the service is a biopsy, destruction, shaving or removal, or excision. Also remember that a biopsy of the same lesion during a lesion removal procedure may be subject to bundling rules, so always check the applicable CAPTAIN and NCCI guidance. For the exam, keep these three rules in mind: biopsy right pointing arrow sample, excision right pointing arrow remove, destruction right pointing arrow destroy. The final rule is identify the intent and technique first, then match the documented procedure to the current CAPTAIN code and guidelines. Now let's focus on measuring lesions and selecting the correct CAPTAIN code. For lesion excision coding, measurement is important because the documented size can affect code selection. The appropriate clinical measurement should be obtained before the lesion is excised. For the applicable excision code families, the basic concept is greatest clinical lesion diameter plus the required margins equals the excised diameter. For example, if the lesion measures 1 cm and the required margin is 0.2 cm on each side, the excised diameter is 1.4 cm. The coder then considers the anatomic site and documented excised diameter when selecting the appropriate CAPTAIN code. Here is the common CPC trap. The surgical wound is 3 cm, so code the lesion as 3 cm. Not necessarily. Do not automatically substitute the size of the surgical defect or incision for the appropriate lesion measurement. Your CPC workflow is identify the lesion right pointing arrow, confirm the site right pointing arrow, measure the greatest clinical diameter right pointing arrow, determine the required margin right pointing arrow, calculate the excised diameter right pointing arrow, select the appropriate CAPTAIN size range. Your CPC memory rule is lesion plus margin equals excised diameter. For 2026 accuracy, always verify the current CAPTAIN instructions and applicable CMS or payer guidance for the date of service. The final rule is measure before excision, include the required margin when applicable, and select the code based on the documented excised diameter and anatomic site. Now let's focus on anatomic site, location, and multiple lesions. For skin lesion excision coding, the anatomic site matters because different body regions can have different CAPTAIN code families. So, before choosing a code, identify the exact location documented by the provider. Think of the workflow as site right pointing arrow code, family right pointing arrow, size right pointing arrow code. When multiple lesions are treated, don't automatically assume that one code represents all of them. Review each lesion's site, size, and procedure performed, and then check the specific CAPTAIN instructions for multiple lesions. For example, if 3 lesions are separately treated, ask, are they at different sites? Are they separately excised? Does the CAPTAIN code provide specific multiple lesion instructions? Do applicable NCCI rules affect separate reporting? Here's the CPC trap. 3 lesions were removed, so simply report the same code 3 times. Not automatically. You must first review the documentation and the applicable coding rules. For 2026 accuracy, always verify the current CAPTAIN instructions and applicable NCCI guidance before reporting multiple codes or modifiers. Your CPC memory rule is: cite first right pointing arrow, size second right pointing arrow, multiple lesion rules third. The final rule is: identify each lesion's documented site, size, and procedure, then apply the specific CAPTAIN and NCCI rules before reporting multiple codes. Now let's focus on margins, depth, and tissue removed. For applicable skin excision codes, margins can affect the excised diameter used for code selection. The basic concept is: greatest clinical lesion diameter plus the required margin equals the excised diameter. The measurement should be established before excision. Next, determine the depth and tissue actually treated or removed. Was the procedure limited to the skin? Did it involve subcutaneous tissue? Or did it involve a deeper structure? The operative documentation must support the level of tissue reported. When reviewing the documentation, ask, what tissue was actually removed? What depth was documented? Was the lesion completely excised? What margins were documented? And does the CAPTAIN descriptor match the procedure performed? Here's the CPC trap. The wound extends to bone, so a bone-level procedure should automatically be reported. Not necessarily. The coder should report the tissue actually treated or removed, based on the documented procedure, not simply the deepest tissue exposed. For 2026 accuracy, always verify the current CAPTAIN descriptor, surgical guidelines, documentation requirements, and applicable CMS or NCCI guidance for the date of service and service setting. Your CPC memory is: margin right pointing arrow measure, depth right pointing arrow verify, tissue right pointing arrow code. And the final rule is: code the documented tissue actually removed or treated, and apply the appropriate margin and measurement rules. Never make assumptions based on wound depth alone. Now let's focus on an important 2026 special point. Always verify the current integumentary coding rules. Integumentary coding can change through annual CAPTAIN updates as well as CMS and NCCI revisions. For 2026, CMS includes specific NCCI guidance for the integumentary system, covering CAPTAIN codes in the applicable surgery range. Before selecting a code, verify the current CAPTAIN code descriptor, parenthetical instructions, surgical guidelines, and any new, revised, or deleted codes. Then check the applicable CMS and NCCI information, including PTP edits, MUs, add-on code edits, modifier indicators, and bundling rules. For an integumentary procedure, also confirm the lesion type, anatomic site, clinical measurement, margins when applicable, depth, tissue actually treated, procedure technique, and multiple lesion instructions. Remember that NCCI files are updated periodically. For 2026, always use the current file applicable to the date of service and service setting. Here is the CPC trap. I memorized this code last year, so I can use it for 2026. That approach can lead to errors. Annual CAPTAIN changes and NCCI updates mean that older information may no longer apply. Your CPC memory sequence is: date right pointing arrow, CAPTAIN right pointing arrow, guidelines right pointing arrow, site right pointing arrow, procedure right pointing arrow, NCCI right pointing arrow, CODE. The final rule is: for 2026 integumentary coding, verify the current CAPTAIN instructions, applicable CMS, NCCI guidance, service setting, and documentation before selecting the code. Now let's apply our integumentary coding concepts to a CPC-style scenario. A patient has 2 skin lesions treated during the same encounter. Lesion A is biopsied, while lesion B is definitively excised. The documentation clearly identifies them as separate lesions and separate anatomic sites. The question is, can both procedures be reported? The correct answer is B. The key is that the biopsy and excision were performed on different lesions. NCCI guidance states that lesion removal codes generally include a biopsy of the same lesion during the same encounter. However, a biopsy performed on a different lesion may be separately reportable when the applicable CAPTAN and NCCI rules support it. So follow this workflow. Identify the lesion, right pointing arrow, confirm the procedure, right pointing arrow, review CAPTAN instructions, right pointing arrow, check applicable NCCI edits, right pointing arrow, report supported services. Here is the common CPC trap. A biopsy is always bundled with lesion removal. That is incorrect. The important question is not simply whether a biopsy was performed. Ask, was the biopsy performed on the same lesion or a different lesion? For 2026 accuracy, always verify the current CAPTAN instructions and applicable NCCI edits for the date of service and service setting. Your CPC memory rule is, same lesion, right pointing arrow, think bundle. Different lesion, right pointing arrow, check separate reporting. And your final exam rule is, don't ask only, was a biopsy performed? Ask, which lesion was biopsied? Let's finish lesson 13. Integumentary surgery, skin and subcutaneous tissue, with a quick review. First, identify the tissue being treated and carefully read the documentation. Next, confirm the anatomic site, procedure performed, measurement, depth, and tissue removed. For applicable lesion excisions, remember that the documented lesion measurement and required margins can determine the excised diameter used for code selection. Keep the three core concepts clear: biopsy, right pointing arrow, sample. Excision, right pointing arrow, remove. Destruction, right pointing arrow, destroy. For multiple lesions, review each lesion separately and apply the specific CAPTAN and NCCI rules. Never assume that the same code should automatically be reported for every lesion. Also remember that wound depth does not automatically determine the procedure code. Code the tissue actually treated or removed as supported by the documentation. For 2026, always verify the current CAPTAN instructions, surgical guidelines, CMS and NCCI guidance, date of service, and applicable service setting. Your CPC master workflow is: documentation, right pointing arrow, site, right pointing arrow, procedure, right pointing arrow, size, right pointing arrow, tissue, right pointing arrow, guidelines, right pointing arrow, NCCI, right pointing arrow, code. And your final 2026 rule is: read the documentation. Identify the tissue and site. Understand the procedure. Apply the guidelines. Verify the current rules. Then select the CAPTAN code. The biggest lesson is simple: accurate integumentary coding starts with accurate documentation. Remember, identify right pointing arrow, verify right pointing arrow, CODE. That completes lesson 13. In the next lesson, we'll continue with biopsy versus excision versus destruction in greater detail.